thank you all for spending this beautiful summer night here talking about ticks. I really appreciate it. I would never have imagined such a packed room, and I'm honored. I'm also reminded when I hear when you present, people present your CV, kind of what you did. I'm reminded of how I was in my training and my wife finally told me I was done and I couldn't do anymore. I had to get back to work. Okay, first slide is the obligatory relationship disclosure slide, and my only real true interest is the cure and treatment of my patients. When I was asked several months ago to give this talk on tick-borne illnesses, particularly Lyme disease, I have to admit, when I first was asked, I kind of hesitated. So I wasn't sure whether is this the right thing to do, because within infectious disease, there are many controversies, and if I were to make a top 10 list, if I were to, an homage to David Letterman, if I were to make a top 10 list, right at the very top would be Lyme disease and tick-borne illnesses. You might be surprised to hear that. My wife was very surprised until she attended a international conference with me, and the large block of protesters protesting the care of tick-borne illness patients really took her aback. But you may be wondering then, why did I agree at this opportunity to, some could argue, entering a hornet's nest of controversy? Well, I chose to because I think it's really important. I think it's an important subject. It's a testament to all of you coming out tonight to hear me speak about ticks and tick-borne illnesses. And I think I have a responsibility as an infectious doctor to share what knowledge I have on the subject and kind of allow you all to see what the latest evidence base is on tick-borne illnesses, diagnostics, treatments, and kind of touch on what some of the controversies are. And then for all of you to take this information and share it with friends and family and colleagues. I've planned on a pretty aggressive agenda, a bold agenda, and I want to let you know what this talk is about. And what this talk is about is ticks. It's about talking about prevention of tick bites, this idea of prophylaxis, which is specific for Lyme disease. We'll talk about that. Talking about a little bit about the epidemiology. What are the numbers we have here in the United States and here in the state of Vermont? We're going to talk about Lyme disease, early and late Lyme disease. This is kind of the designations that the CDC and the IDSA makes, and we'll talk about that. We'll talk about anaplasmosis, babesiosis, and we'll touch on these controversies. I have to qualify my talk on a whole by saying I'm an adult infectious disease doctor. So if you came here really looking for information on pediatric infectious disease specific to tick-borne illnesses, I apologize in advance. It's not who I am. We have wonderful colleagues at both UVM and Dartmouth who are pediatric ID specialists. It's a specialist in its own right, who might be able to answer many questions you might have. What this talk isn't about is, I know there's a lot of debate and controversy about tick-borne illnesses, Lyme disease, and the others. This isn't what this is about. A debate would be in a much different venue and much different format. What I'm hoping to do today is to really share with you the IDSA, which is the Infectious Disease Society of America, the CDC, the NIH kind of perspective on tick-borne illnesses. So again, my second apology in one slide. If you're looking for a debate, it's really not going to be a debate. I will answer questions, as Matt alluded to at the end, but you need to know my answers are coming from this perspective. That's my practice model. And I want to thank you in advance for respecting that, because I've been to many talks on many different subjects where what's supposed to be a presentation kind of becomes a debate. And again, that's not why I really want to do this today. If you're interested in where I'm getting this information, this is the supplement. All right, it's about 10, 12 pages. The full guidelines are about 100 pages. They're in-depth, they're detailed. If you have trouble sleeping, they're great to read because they can be incredibly boring. But they're really packed full of information and references, and that's where most infectious disease doctors in the United States draw upon the information to be able to apply that evidence-based medicine to our patients. Again, anyone who has any questions about where this is, it's idsociety.org, and the guidelines are free and open to the public to read.
What did you say, ID?
idsociety.org. I apologize, I probably should have put that in there. Now while we're here to talk about ticks. And the main tick I'm going to talk about is Ixodes scapularis. It's a black-legged or deer tick. And it's a tick that's responsible to up to 7 diseases, known diseases in humans in the United States. But the 3 pathogens I'm going to talk about today are Borrelia burgdorferi, which is the cause of Lyme disease. You have Anaplasmosis phagocytophilum, which is anaplasmosis, and Babesia microti, and that's what causes babesiosis. Now there are variants, for example, in Babesia, but really what we see most often in New England and in the United States is Babesia microti. And down there on the bottom right, your right, that is our Ixodes scapularis, or black-legged tick. Trust me, you're going to see much more of that. But because I'm an ID doctor, we're all about history and how history repeats itself. This gentleman right here is Willy Burgdorfer, and he's actually your first fun fact. He's a clinical microbiologist, and he actually was the microbiologist who discovered the bacterial pathogen that causes Lyme disease. Hence the name Borrelia burgdorferi. So I guess in that world, that's the coolest thing that could happen to you when he had an infection named after him. You should all be so honored to have that happen to you. So here is, I'm going to turn like this. I apologize for having my back to you guys. This is our black-legged tick, our Ixodes scapularis tick. And you can see there's a big difference between males and nymphs and larvae. And we'll go into that in a little bit. But the males and females are distinctive in the way they look. You can see this kind of blackened shield on the, for the back, the lack of better term, the trunk of the female, while the blackened shield covers most of it in the male. But you guys are going to become somewhat experts on these ticks before we're done today. It's also important to note, these are really small. And we're going to focus on the black-legged, or again, Ixodes scapularis ticks. We're not going to talk about the Lone Star ticks or the Dermacentor variabalis tick. We're going to talk about our tick that carries infections that cause Lyme, Babesia, and anaplasmosis. I need to point out that the tick is carrying this infection in its gut. Again, I apologize for not mentioning this right up on the bat. It's the tick biting you, and that organism that's living in the tick's gut that then goes, while the tick's getting a blood meal, we're going to talk about that, it goes from inside the tick into you, okay? So this is why later on we talk, the tick has to be feeding for you to get an infection. A tick that's crawling on you, you're not going to get an infection. The tick has to feed, and not every tick carries these organisms inside of them. So just because you've been bit by a tick doesn't mean you're going to get infected. The qualifier in that is we live in a state that a lot of our ticks carry a lot of infections. Okay, some states they don't carry as much. Vermont does. But just look at the size. I mean, that's a quarter of the size of a dime. We all know what relative to the scale a dime is. Look how small they are. The females look big, but still they're very small. And these ticks can carry diseases that could give us infections. I'll figure out this movement probably by the very end. I want to focus on the life cycle of the tick, and in this slide, 2 things I want you to take home. Is first, you can see we start up here. I'm not going to use the pointer. The eggs hatch in the larva, then the larvae feed, and then the larvae molt into nymphs, and then the nymphs feed, and then the nymphs turn into adults. 2 things to take home from this: look how small they are. Again, there's a big difference between the adults and the nymphs in particular. And who's missing from this life cycle? We are. We're an accident. We kind of get in the way. We were never intended in the original life cycle to be in there, but we are, and as many of you know, we can get very sick from this. Looking at the life cycle a bit of a different way, we're going to look at it recognizing from spring to fall is the time of the year that most cases are seen for these infections. For anaplasmosis, for Lyme disease. We see these cases most often then. And so what stage of life cycle is most predominant? It's the nymphs and the adults. Now remember how small that nymph is. And this is why a lot of people get infected and never know they've even been bit, because these nymphs are tiny. Flecks of peppers, the way they're often described. And this is a very active period of time when they're feeding, and it just so happens to correspond that when we're very active going outside and doing stuff, hiking, gardening, doing quite a few activities. So that's the take home from that. But it's important to note, you can get any one of these tick-borne illnesses any time of the year. You can have ticks who will feed in the wintertime if it's a mild winter, and so there are cases reported of people getting tick-borne illnesses in the winter. It just emphasizes the need, and we'll get to that, of the importance of tick checks. So the take home here is that nymphs and adult females are the big carriers of this infection. I'm going to delve in this in a second a little bit more, and that's spring, summer, and fall. I don't have the exact statistics, but the trend is that the adult females, or the adults, are most often the ticks that are carrying these co-infections, carrying the Babesia, carrying the Lyme disease, carrying the anaplasmosis. Nymphs don't carry it as often, but here's the thing. You notice adult ticks on you. You notice when an adult tick is feeding on you more often than you do a nymph. So actually, when you look at the risk is that you get probably bit more often by a nymph and never know it. Therefore, we tend to be more worried about those because the adults, you kind of see it coming often, but with the nymphs, they're so small you don't often see it coming. And I'll show you a picture later on of a nymph that's engorged. And honestly, if this was in the back of your knee or on your back, you might never know that you were even being bit by a tick. So how do ticks kind of hunt us down? What is their, I won't say their motivation, because their motivation is a blood meal. But what ticks do, it's something called questing, and the insect biologists love coming up with these terms. So what happens is ticks will climb to the top of blades of grass, other high grasses, meadow grass. They'll climb up on leaves or twigs or anything, and what they do is they sense movement. Sometimes they sense heat. Sometimes it's biochemicals like carbon dioxide they sense. It kind of, one person once said to me, it's kind of why some people get bit and some people don't. We really haven't sorted out what attracts ticks more so sometimes than others. But these ticks, what they do is they climb to the top of these, and this is just a blade of grass, and they latch on with their bottom legs, and then they raise their top legs up, and they wait for you to walk by, and they hook on you. And that's what they do. So they're motivated to get to you. If it makes you feel any better, which I doubt it will, our ticks are somewhat passive when it comes to ticks when you're looking worldwide. But there's ticks in, I've had patients return from safari in Africa and they're surprised they got bit by ticks because they said, oh, we were just squatting down in safari, we weren't really in the brush, and we looked around, we didn't see any ticks. Well, those ticks are a lot more aggressive, and they're thought to hunt you as opposed to you kind of walking into them. So that leaves you with something good to think about. And here's some other ticks that are questing. You can see this is the Lone Star tick, but that's a male Ixodes scapularis, which I knew you'd all be able to identify if I called on any of you. All right, let's talk about what's tick's motivation. The tick's motivation is to get a blood meal, to feed, to embed. And you can see here, your upper left, that is a nymph that's feeding. I told you they're really small. And so again, what if it's behind your ear? What if it's on the middle of your back? You might not see it. These are a little more obvious, the upper and lower corners there. And I like to think of this as the before and after picture. I won't ask you to raise your hands, but a lot of people here probably have dogs, and you're familiar with ticks getting engorged on your pets. And so you have a concept of these ticks. Now, this is why the adults are so, although they may carry infection more often, they're much more noticeable. And no one's going to let that ideally happen like that on them. But this could happen. You get a tick on you, and you might not know. So we're going to talk a little bit about what to do with that, so don't be anxious about that. But this is just an example of why The nymphs are the ticks we get most concerned about, but really, in total, I want you to be vigilant for all ticks and all exposures potentially to ticks. So what's the best way of preventing an infection from ticks? Getting either Borrelia burgdorferi, Anaplasmosis, Babesiosis, for that matter, any tick-borne illness, it's pretty straightforward. Avoid tick-infested areas. But that sounds so simple. Like, oh, I just avoid them. But if you live in Vermont, it's really not possible. If you go out of your house, walk across your yard, you're potentially going to be exposed to ticks. So what do we do? Well, there's several steps you can take, and they seem very common sense, but I still think it's important repeating. Frequent visual inspections of skin and clothing. When you come in from outside, do tick checks. It should become habit. It should be habit year-round, but especially spring into fall. So check your clothing, check your skin. One study described taking your clothing off, putting it in a dryer on high heat for about 45 minutes. That'll kill the ticks. I tell people if you're coming in from doing yard work or hiking, take a shower. You're not going to knock off that embedded tick, but you're going to knock off maybe that tick who's just crawling on you and hasn't embedded yet. And then when you step out of the shower, this is your vanity moment. You're allowed to do it. Stand in front of a mirror and just check yourself out. Okay? And if anyone walks in and catches you, say, well, I'm looking for ticks. You know, any excuse you want. They might be suspicious if it's like dead of winter and you haven't left the house, but say, I'm looking for ticks. Employ a partner to look for ticks, and I'll leave it at that. But look for ticks. That's the most important thing you can do. And if you find a tick, we'll tell you what you're supposed to do with that. If you go out, wearing long sleeve shirt tucked in helps provide that barrier between your skin and a tick. Long pants, barrier between the skin and the tick. I understand that's not necessarily realistic when it's 90 degrees, 100% humidity, but it's just important to note that these are potential avenues you can take to reduce the exposure to ticks. Wearing light colored clothing, the key to that is background, where you can see the tick on your khaki pants or a white shirt much easier. Fortunately, again, this is meant to make you feel better, it may not. Certain ticks outside of North America, they're finding may be more attracted to lighter clothing. We don't have those here yet. So if you go on a trip, you're going to say, Dr. Cotter told me about all these bad ticks here. But all these are meant to protect you before you get exposed to the tick. Another thing you could do, oops. Let's see if it skipped here. Oh, okay. Sorry about that. So if you do get bit by a tick, it's important to remove it. Prompt removal. Don't think about it, don't hem and haw about it, remove it. If you're nervous about removing it, ask somebody who knows how to remove it. Contact your primary care provider, urgent care, be it your MD, DO, NP, PA, whoever, and get that tick, remove that tick, because you'll find out a little bit later, time is tick in some respects with some of these illnesses, so the sooner you're able to remove a tick, the better. Now, it's pretty straightforward. They say use this fine tip forceps tweezers and try to grab as close to the skin where the tick is, all right? Now, I was always taught growing up, oh, you can't leave the mouth parts stuck in there, that's gonna cause more problems. And I remember, I grew up in Connecticut, so if you know anything about Lyme disease, it started in, so it's funny, where I've lived, they've had a lot of ticks, so I'm wondering if I'm bringing them around with me. But we were always taught you gotta dig out those mouth parts. Well, that's an absolute no-no, because you're just gonna cause potentially more problems, maybe cause a skin infection from other bacteria if you start digging around. The thought is if you remove that tick promptly, you grab as close to the skin as you can. If you leave some bits in there, not ideal, but okay. Just use topical, use rubbing alcohol or some kind of topical antiseptic on it. And that's what's really recommended. Pardon me? Yeah, they're not fun to remove. If anyone's removed them off dogs, they know they really hold on. And so it's there's a lot of different recommendations and YouTube videos if you're into that. You just hold them and you slowly pull and they will let go. Another preventive tool is insect repellent or tick repellents. And you hear a lot of people talk about DEET products, and I'm a proponent of them. You don't need 100% DEET. I know it's been out in the public, oh, 100% DEET's what you need. No, you really only need 20 to 30% DEET. That's effective. And I tell people, apply it to your skin, apply it to your clothing, reapply it, especially if you're going out for hours, let's say you're hiking or gardening and you break a good sweat. It's somewhat, I say it's analogous to if you're using sunblock, you got to keep applying sometimes. Well, you got to keep applying this insect repellent. The key thing too is it can be a little irritating to your skin. So when you come in, this is your other motivation to take that shower and wash that and do that tick check. You can wash off the skin, potential skin irritant in these DEET products.
What about
permethrin?
Yeah.
Permethrin coated clothing, thanks for bringing that up, is another avenue. To be honest with you, it can be very expensive. Okay, but I know Orvis and EMS, there's a lot of different places that sell it. Elo Bean, to make sure I have no financial interest in those companies, so I don't want to make sure I forget one. But permethrin coated clothing is definitely an option. We were just talking before, I don't recommend wearing your dog's tick collar as a preventative. I was actually asked that, saying, well, my dog doesn't tick ticks. Can I wear his collar when I go out for a hike? And I said, I don't even know how to answer that, but sure. I go, people are going to make fun of you, and anyway. I don't recommend that, period. I'm going to end right there. One thing I'll say about
when do you have to have the reapplication?
It's a good question. I was just asked that earlier today. It's a judgment call. If you feel like you've sweated it off, I say if it's an hour, you're on a brisk hike and you feel it's kind of on your clothing, it'll stay on your clothing, but on your skin, you might, each like Deep Woods Off and stuff, they'll give you sometimes instructions on the timing of applying it. But if you're an hour or two and you're really sweating, you might want to consider reapplying. I meant to mention about the removal of the ticks. There's some debate, but I'll be honest, there's no literature on this, about removing the tick. So I said try to grab it from the side and pull that mouth part up. There's a question of what if I grabbed it right from the top? Am I squeezing it and forcing more of that infection into, let's say, my spouse, my child? There's no data supporting that, so I really can't comment on that. To me, the easiest way to get around that is just try to do the best you can by not grabbing the body and grabbing as close to the mouth as you can.
I've taken several ticks off my husband, and I've had good luck doing it. What I've done is I've taken tweezers, and I just move a little bit to the angle,
Yep.
and I turn and pull, and I've gotten the whole tick every time.
There's a lot of different there's a lot of techniques where you twist, and then you twist the ticks off.
I start out here, and I just turn and pull, and every time I get the whole tick.
Anyone ever had a question on tick removal? She's your expert after.
Seriously.
Where's her husband? He's not here, I see. Okay, we're going to point at him when he comes in.
Seriously, I check him for the ticks, and he has Lyme disease.
Yep.
So I check him all the time. But seriously, I'm an expert getting out the whole tick. And we actually even look at him, he's got these special glasses, and we look at the tick to make sure we get the whole tick.
There you go.
But it's been very effective.
Good.
And they're just regular tweezers.
Yeah, you don't need, there's certain specific tools you can get, and they're very good. And then tweezers are good too. You had a question over here?
Can you repeat the question for everyone, because we're not hearing it?
Oh, I'm sorry. We were just talking about the technique to remove the ticks. And, there's two questions. Reapplying DEET products, when do you reapply? And I said, two things to think about. First is you can look at the actual instructions on, say, if you're using Deep Woods Off for an example. But also if you're out and you're active and you're building up a good sweat and you think maybe you've sweated off some of the insect repellent, then you reapply. Your clothing you often don't have to reapply. That's one of the benefits of the permethrin clothing. It's applied and you don't have to worry about it anymore. But like I said, I'm not going to sit up here and say it's cheap. It can be expensive. And there was a question over here and then I'm going to keep going.
We bought the tick pullers at a pet store.
Yes.
And it actually has a little fork, you put it around it, and you do the twisted motions.
If you go to Walmart, again, I have no financial interest in Walmart. I feel like I have to say that every time. They have a whole wall of tick removals now. If you wondered if we have a tick problem here, Walmart's loaded up a wall just on tick removals. So we'll keep going here. So this is actually a really interesting subject, and this is I'm giving you a bit of an inside baseball's view because portions of this talk I recently gave over at the hospital to the physicians and the nurses and the PAs, because I wanted to let them know kind of the up-to-date clinical and medical perspective on tick-borne illnesses, and I thought it was important to share with you so you knew what your providers were thinking. There's this idea of, you can see it's prophylaxis for Lyme disease. It's specific for Lyme disease. I will mention at the very end the thoughts on prophylaxis for, we'll just focus on Babesia and Anaplasmosis, but this is specific for Lyme disease. The goal of this is that if you have a tick on you, we can ideally get that tick off and give you 200 milligrams of doxycycline times 1 and prevent you from getting Lyme disease. So it prevents everything, ideally. That's the keyword, ideally.
My veterinarian told me that, believe it or not.
Yeah, ideally. But for this to truly be effective, 4 criteria have to be met. And if they're not met, the success is diminished. First criteria is the most complicated criteria, and I put it all up there in one bite because we're going to work our way through it. I'll read it all and then I'll break it up. So the first criteria that has to be met is the attached tick can be reliably identified as an adult or nymphal I. scapularis, black-legged tick, that is estimated to have been attached for greater than or equal to 36 hours on the basis of the degree of engorgement of the tick with blood or uncertainty about the time of exposure to the tick. You all got that. Do I have to tell you anymore?
You have to save the tick.
It's a mouthful. So, no pun intended, a mouthful. I didn't realize that. The first thing is identifying the tick. If it's not Ixodes scapularis, the black-legged tick, which you're all experts on identifying now, then we're not dealing with Lyme disease in Vermont. So it's a non-starter. You're not a candidate for prophylaxis for Lyme disease because you don't have the tick that carries Lyme disease. The second thing is if you identify it, it's important to get an idea whether it's an adult or a nymph, but I give you credit if you identify it. That's kind of, if you identify it as that, that's very important. Now, how long do you know it's been attached? What's with this 36 hours? Well, the thought is, if a tick is removed before it's been in place, been engorged, been embedded for 36 hours, then it's unlikely that that organism, that Borrelia burgdorferi that's living in the gut of the tick, has moved into you. So 36 hours is key. Why is that important? Because if you find a tick on you, if you get up in the morning, no ticks, go out and garden all day, and that night find a tick on you that's embedded, if you pull that tick out, it's unlikely that you have acquired any tick-borne illness. Okay? But I could say that with most assurance for only Lyme disease, and that's why I'm going to get back to some of the other tick-borne illnesses and how long it takes them to be attached to potentially cause a problem. But how do you know? Well, you could be certain if you worked in the office Monday through Friday and you finally get out on Saturday to finally work in your yard, and then Sunday night you're relaxing and you notice a tick on you, then you have an idea, maybe this tick's been on me for 36 hours. So this final statement about the certainty is probably one of the easier parts of it. Not for you guys, because you guys can identify ticks with any problem now. But the engorgement, the size of engorgement, there's actually something called the Scuttle Index. Don't ask me why they came up with this, but I read the paper and it's kind of actually interesting, and I'll show you something in a moment. But you can tell how fat the tick is. It gives you an idea of how long the tick's been on you, believe it or not. I know you all look very excited for when I describe it. So a little review, a little refresher, because I know you all know this, but identifying the ticks, identifying the nymphs and the adults. But this is another metric of looking. These are so small. Hold on, I want to make sure I have all my slides here. So how do we know how long the tick's been on you? By the size of by its size, basically how engorged it is. And again, this is something called a Scuttle Index. And what they did is they took these ticks and they put them on a medium where they let them feed, and then they measured the size of them at different hours. And that's where they came up with these. This is some lovely work by a grad student, I'm sure. And the professor's like, go feed our ticks and measure them. And so that's how they were able to somewhat measure by the size of the tick how long it's been on you. Okay, so first criteria, let me get out of the way. Black-legged tick, been on you for greater than or equal to 36 hours. And you can tell that by either knowing or knowing the size of it. And a little review on it. You can't miss the adults when they're fat. So what are the other rules? Remember I said there was 4. You have to be able to start antibiotics, that doxycycline 200 milligrams, one time within, you can see that 72 hours of that tick being removed, which generally isn't a problem, to be honest, here in this part of the country. But it's important. You don't want to take that tick off and say, I'll think about it later. No, it's important that you get that antibiotic on board relatively quickly. This is, I'll do this one for you. You have to have a local rate of infection in your ticks with Borrelia burgdorferi, remember the cause of Lyme disease, of greater than or equal to 20%. And that's Vermont. So that's a no-brainer. And the final one really isn't much of a problem. It's that doxycycline isn't contraindicated. It makes sense. If you're pregnant, you're less than 8 years old, or you're allergic, then all this is moot because you can't take doxycycline anyway. So those are the 4 criteria. You might ask, how successful is this? You should be asking that. The original studies when they came out showed that you needed to treat about 10 to 12 people to have one person not get Lyme disease, which doesn't sound great. But when they really tightened up the criteria and made sure people really applied these 4 criteria, the rates improved to greater than 90% success of avoiding getting a tick-borne illness. So this works, but it's got to be done right. And the problem is, and what you hear often is, it doesn't work. And there's reasons for that. It comes into the timing, it comes into whether you got the right antibiotic, it comes into, so there could be problems. You might not even have Lyme disease, and that's what people often will argue about. But it's important, irregardless, once you get this prophylaxis dose, you still have to still be in contact with the health provider for the next 30 days. Because remember, it's not absolute. You still could get Lyme disease, or you could get another tick-borne illness, and you could presume that you had Borrelia burgdorferi, the cause of Lyme disease, but it could be anaplasmosis you've acquired, and it could be babesiosis you've acquired, and I could go on and make you all uncomfortable, but I won't. But there's other tick-borne illnesses you can get. And I mentioned, the thought is if that tick is removed within 36 hours, then you have in a lot of cases circumvented getting Lyme disease at 36 hours. We don't know with the other tick-borne illnesses, to tell you the truth. It's believed that anaplasmosis, if that ticks on for 24 hours, that potentially you will get infected. And we have a new tick-borne illness, Powassan virus. I don't know how many of you have heard of that. It's been in the paper. It's thought potentially minutes to hours it can transmit. We're talking very quickly. But this is really meant to focus specifically on Lyme disease. We'll transition now to some epidemiology. Basically, I'm going to discuss where we are with regard to Lyme disease in the United States, anaplasmosis in the United States, babesiosis in the United States, and in Vermont. I have to thank the state of Vermont, Health Department of Public Health, who provided me some raw data. I put it in kind of an easy for me to see graph form, but it's, I want to let you know where we are with these illnesses. We'll start off with Lyme disease cases in the United States, and I'm going to quickly move through these slides, but I want you to follow them with me. So this is one dot, basically represents a case report, and you can see this is in 2001. And look over this time period. More and more cases we're seeing. Okay. And another way of looking at this is straight from the CDC. Over time, and this is up through 2015, but it's thought to be that this number keeps trending up. We're seeing more and more cases of Lyme disease every year. You're all experts on the life cycle of ticks now, and you know early spring to fall is when we have most of our active ticks, and that fits right in there. Looking at April to September, these are when we're seeing most of our cases of Lyme disease. The most common presenting symptom in some studies, up to 70–80% of the time, is something called erythema migrans, which again, you guys are going to be experts on before you leave here. But it isn't always, but for lack of, I'll just say right now, it's the bullseye rash. That's the most common presenting symptom we see. But you can see there's an awful lot of other symptoms that can present with Lyme disease. This is a slide I find it kind of interesting because it's not really explained why this happens, but I have my own theories, having boys and girls as kids. As you can see, the most common, it's an interesting mix in ages, and this is cases based on age and sex. And you can see kids, more so young boys, and I have young boys, and I know they get into everything, and they go and they don't, yeah, I check for ticks, yeah, I took a shower. So I think they're more at higher risk just for being young boys. But what's interesting is these young kids getting Lyme disease is if you look at the history of Lyme disease, in Lyme, Connecticut, it was a series of cases that were diagnosed as juvenile rheumatoid arthritis by Yale New Haven pediatric rheumatologists who realized, wait, this is too many cases. And they really were able to determine that it's actually not juvenile rheumatoid arthritis, it's actually from something new, and that something new was Borrelia burgdorferi and Lyme disease. But you can see this peak with kids, and then it get this lull, and then this peak again, more, I won't say middle age because I'm in that age now, it's still young. But what's interesting, I have a theory on why this is. You can't get teenagers or 20-year-olds to work in your yard, so that's why Now we're going to transition to anaplasmosis. Here's what you need to know about anaplasmosis from an epidemiologic, or where do you see these cases? Where there's Lyme disease, there's anaplasmosis. They kind of go hand in hand. I already told you it's the same tick, but we see these cases in the same areas. And this is where I mentioned before. Matt mentioned I born in Connecticut, trained in Massachusetts, and I trained in Minnesota. It's like, wait a minute. Everywhere I'm going, I'm seeing these tick-borne illnesses. I take no credit nor blame, although it is job security. You see the number of cases, again, similar to Lyme disease. We're seeing more. This is only up to 2010. This is right from the cdc.gov. You can see the upward trend in cases, and we're seeing more and more cases. This is, again, your experts on the life cycle. Same as Lyme disease. Early spring, in the fall, these are when we see these cases. It fits. I like it when everything fits. Here's what's interesting, though. You don't see anaplasmosis in kids that much. We see an increasing incidence as one gets more seasoned, I won't say older, more mature. We see more and more cases. We don't see it in kids as much as one would expect, given the fact it's the same tick that carries Lyme disease, that carries anaplasmosis. Why don't we see it in kids? And I don't believe, to my knowledge, and I have to defer to my pediatric ID colleagues, that that's really sorted out exactly why. This slide isn't to point out 2003 as being any particular unique year with regard to tick-borne illnesses, but it's really it's not meant to create a somber note, but it's meant to point out that these tick-borne illnesses are real, which I know you agree with that to this point, but they're serious. People die from these. There's a fatality, a mortality associated with tick-borne illnesses, and it's not something we could just ignore. We're seeing them. We see patients ill enough that they have to be admitted to the ICU. We have them right here in town. So these are very serious illnesses. And our final tick-borne illness we're going to talk about from a United States perspective is it's Babesia. So Babesia microta. And Babesia is most often seen in Martha's Vineyard, Block Island, Nantucket. As one person at one conference, it's the beautiful people's disease. But this is where we see most cases. But again, we see it out in Minnesota and Wisconsin, interesting enough. And this is CDC data national, but I do have our state data, and the trend is also increasing with this. We're seeing more and more cases of Babesia nationally. Again, I have to thank the state of Vermont Department of Health for giving me the raw data, but this is raw data up to last year. We had 759 cases of Lyme disease last year in this state alone. And when you look at 2015, all right? When you rank all the states in the country, Vermont by numbers comes in 11th. Which one? We're only 11th. That's just raw numbers. When you work it out by population, we're number 1. We have the number 1 instance of Lyme disease in the Union, which I don't think Governor Scott's advertising, nor is the Chair of Commerce, but we have the number 1 instance of cases of Lyme disease in the country. Anaplasmosis, you can see we have quite a few cases of anaplasmosis, 201, and I would argue our numbers are going to be higher this year. If you were to ask any healthcare provider, either in primary care, at the ED, or hospice, or inpatient at RMC, we're seeing more and more cases of anaplasmosis, to the point where at first I thought it was almost comical that you think, oh, it's going to be a tick disease again, it's going to be a tick disease again, but it is a tick disease again. We're seeing quite a few.
Are you going to explain to us what that is?
Yes. I set you up. And babesiosis, we had 15 cases last year in Vermont, and we're going to talk about each one of these. I'm going to talk about each one of these illnesses. And the way I'm going to set it up is I'm going to present several cases. So you're all, because you're experts now, you're all going to think about this, and I'll take 1 or 2 comments. So Mrs. C, she's a 69-year-old female who presents to your office with a new rash. You noticed a tick on her about 2 weeks ago. She states she likes to walk in the woods. This is, you may think these are the stories you get. People present to you. Any thoughts, or is it pretty straightforward? What questions would you ask?
Was the tick embedded?
Good question.
Was it where the rash was?
You were signed on now, doctor. Yeah, what kind of rash? So we're going to talk about Lyme disease. And the CDC and IDSA breaks down Lyme disease into early Lyme disease and late Lyme disease. And I'm going to touch on some of these, some more detailed than others. For example, I'm going to really go into depth about erythema migrans, disseminated EM, because I think you guys, I want you to know, I tell all my patients, the more you know, the better your outcome is going to be. And the more you know, your family members are going to do better because you recognize certain telltale signs. There's some early neurologic Lyme disease. We're going to talk about things like Bell's palsy or meningitis. We're not going to go too much into detail, but I want to give you a taste of what doctors are thinking behind the scenes, and NPs and PAs. Cardiac Lyme disease, we're going to talk about something called Borrelia lymphocytoma. We're not really going to touch on, but that's the clinical manifestation of the disease associated with early Lyme. If anyone really has an interest in it, please find me after, and I'll connect you with a link for that. We're going to talk about late Lyme disease, rheumatologic, touch on late Lyme, late neurologic Lyme, but not that much because it's really complicated. And to tell you the truth, it's at that point, Dr. Britton, Dr. Sweet, and I they're the neurologists in town. The 3 of us are really wrapping our heads around it because it can be very complicated. And then there's a condition called acrodermatitis chronica atropicans. Sounds like I know what I'm talking about, but it's a very odd, atypical, European-based kind of Lyme disease entity. We're really not going to go into it. Again, anyone really interested in it, I'm very interested that you're interested in it, but I'll give you information after.
So if somebody was diagnosed with Lyme disease, Mayo Clinic and all, and never treated for it, and the doctor told them, oh, you're over it. Now, is that the case, or will they get late Lyme disease later?
We're gonna talk about that. We're gonna get to that. Not yet, though. So, but let's go right into early Lyme disease. And we're gonna talk about erythema migrans. Again, to give you this is the bullseye rash. But you realize quickly the bullseye is not always the bullseye. So this is a round or oval expanding erythematous or red skin lesion that develops most often at the site where you've been bit by the tick in the Borrelia burgdorferi, or that Lyme disease bacteria has been basically have it deposited in your skin. You get this rash usually a week to 2 weeks after you've been bit. And often people don't even remember getting bit, to tell you the truth. Remember, those nymphs are tiny. But it can happen anywhere from 3 to 30 days. The key thing here is it's got to be at least 5 centimeters. You can see at the largest diameter to really make it consistent with erythema migrans, because there's a lot of confusion at times with erythema migrans. And studies have shown that 70 to 80% of people who develop Lyme disease get one of these rashes. And this is the classic. You never see this, I'll be honest with you. This is too perfect. If you saw this, I'll get out of the way. That's the bullseye. If I see that walk in the office, I'm like, I call everyone in. I say, come look at this, because you don't see this. It just doesn't present like this.
No.
It historically has, and I think it's important to note that it's a bullseye rash because it gets you looking for rashes, but more often it could present like this, and I have several pictures. You can see maybe there's a bullseye here at one point, but it's kind of faded. It can be a very faint rash. It's not as obvious all the time. It could also present like this. This on top is a single Erythema migrans, or EM. And you can see that little ulcer in the middle? That's likely where the tick bit you. Remember, the tick's burrowing into your skin, and saliva and enzymes in your skin's breaking through there. So you can get a localized reaction. And we're going to talk about it because the localized reaction alone isn't Erythema migrans. You have to have that erythemus, that reddened kind of lesion that's greater than 5 centimeters in size. So this is a single one. This patient had multiple ones, actually had 140 of them. And that's disseminated. It doesn't mean they were bit 140 times. I guess I should have said that first. It doesn't mean they were bit 140 times. What happens is you can get that Borrelia burgdorferi, that infection in your system, and it's disseminated. That's disseminated EM.
What if somebody had both?
Had both what?
My husband had both of those.
It could have been 2 different episodes. Normally you're not going to have, you're going to have one. It's okay. Don't worry. You could have, if you present, you either can present with one or multiple. Okay? But they're treated the same way. And the success in treatment is the same for both too. You can get this red oval plaque on your trunk, like in your belly, or you get them behind your knees. Now, you can get them that you get this red rash with a blister in the middle. And now that's atypical. That's like 5 out of 100 will present with that blister in the middle, but it can be Erythema migrans with that blister. The important thing to differentiate between is make sure it's not a contact dermatitis. What's a contact dermatitis? We get in the summer poison ivy. So if your EM is itchy, it's probably not Erythema migrans. It's probably something different because Erythema migrans isn't classically itchy. Also, people can get cellulitis. I'm sure we've all known somebody in our life who's gotten a cellulitis, a skin infection. Where you get Erythema migrans is usually different than where you get your general community-acquired cellulitis. For example, you get Erythema migrans in your armpit. You get them on your trunk, or you get them behind your knee. That's where the ticks go. Okay? Remember, they're attracted to that warmth. They try to go to the spot right there, and you don't notice them. And that's a difference. And your doctor should be able to tell the difference to a certain extent between whether it's Erythema migrans or maybe it's a cellulitis. Sometimes it's hard, I'll be honest with you. It's hard differentiating between the two. And so what we tell people to do is to just follow it and get a better idea. Have you had cellulitis before? Is this similar to your cellulitis? Have you been out in the woods? Is there something in your story that makes me tip one way or another? These are some other representations. This bluish hue without central clearing, or this red expanding lesion with a central crust. You can see they present all different ways. So we like to say bullseye, but they're not always bullseye. Okay. Let me peruse those for a minute. But I mentioned, this is very important. It's kind of obvious there's a tick there, but you can get a tick that digs into your skin in beds, and you get a red mark around it. And you can see kind of the reddish mark around there. That usually happens if you get this reaction. It's in the first 48 hours, and it's more of an allergic or a hypersensitivity reaction. It's not Erythema migrans. You may say, well, then how do you tell the difference? Remember, Erythema migrans usually starts a week or 2 after, but can start as early as 3 days. So what we tell people to do is obviously remove that tick. Don't sit there and wait and see what happens. Take that tick out and measure it. You can often take a marker, mark either side of it, and measure it. If that expands past 5 centimeters, then you're actually potentially entering the range of Erythema migrans. You had a tick bite, now you have Erythema migrans. If it never gets to that big, it's unlikely that it is Erythema migrans, which is, again, associated with Lyme disease. Why is this all important? Why am I harping on Erythema migrans? is really important. Because Erythema migrans is the only manifestation of Lyme disease in the United States that is sufficiently distinctive to allow clinical diagnosis in the absence of any labs. So if you present to your doctor or your nurse or your PA, whoever your primary caregiver is, and you have erythema migrans and you don't even have to recall a typical exposure, but you're in Vermont, then you're diagnosed with Lyme disease. Okay. What confuses stuff, and I'll get this a little later, is when people go ahead and order labs and they say the labs didn't show I had Lyme disease. And they told me I didn't have Lyme disease, but I had this rash. The problem is the reason we don't recommend the labs is because there's issues with them potentially when you first acquire the illness, that the sensitivity and specificity isn't as good. And that's kind of a muddy way of describing it. The take home is you don't need the tests. Okay? That's enough to make the diagnosis. And so the fact that now you all know what erythema migrans is, you know what the ticks look like, this is where knowledge is power. You're more apt to recognize this rash and present to your provider early rather than waiting and say, I had the rash, I was exposed, I need to be treated. And say, Dr. Cotter said I had to. And then I'm going to call from the doctor yelling at me. So what's the treatment? The treatment is doxycycline or amoxicillin or cefuroxime. Treatment is 14 days. One of the local doctors used to laugh, said, UID doctors, you always give us ranges. It drives us crazy. Why do you say 10 to 21 days? Without getting into too much boring minutia, it's because the studies on the individual drugs showed them effective at differing lengths of time. And instead of really confusing things by saying, all right, 10 days for this, 14 days for this, we're able to simplify it and make it 14 days for everybody. Okay? And that's it. And the success is very good for treating this. Okay. Pardon? Which question?
The milligrams, is everybody different as far as the milligrams?
No. Doesn't matter how big you are or small you are, it's the same.
And if somebody does that 14 days, what if they still have Lyme disease? Should they go on it more?
No, we'll get into that because
Okay.
the question is, they don't have Lyme disease anymore. The question is, what do they have? All right.
Okay.
It's a really good lead-in, but you're about 40 slides ahead.
Coming back to the erythema.
Migraines, yep.
How long is its life? Is 1 day, 2 days?
No, it can last several days, even weeks. You can have that rash continue.
So if I notice this erythema and it's just 24 hours, should I rush to the doctor or it's over?
Well,
Something else?
Normally it's not present within 24 hours. It usually presents, the earliest you'll see when you look at the studies, the ranges, or earliest you'll see is 3 days. It's usually a week or two after. The thing is, you might not remember or not know when you were first exposed. So I don't want you guys to fixate on, well, unless you're absolutely sure of when you were exposed, then if you have erythema migrans show, you should see your doctor, okay? Because you don't know for sure how long you've had it, and because you might have been bit by a tick 2 weeks ago and not even know. Remember, you're experts on nymphs. Those tiny little nymphs, you might have bit 2 weeks ago and not known about it, okay? So, but the rash does last for some time. Now, we do see patients who present who have a scaling on their rash. Erythema migrans doesn't have a scale, but what ends up happening, I often ask the folks, I say, oh, did you put a steroid on it? And they'll say, yeah, I got a rash. And that's when the rash can sometimes present atypically, is when people use over-the-counter treatments on it. And that's important. And I'm not saying not to do that, because if you remember we talked about contact dermatitis, most of these rashes are because you've been exposed to something, some kind of, whatever you're trooping around your garden or in the woods about, you get exposed, and topical steroids often help, but they can kind of blur the presentation of erythema migrans sometimes. So that's the treatment, okay? And we're going to talk a bit more. And I put all these qualifiers in there, but I don't want you guys to get too fixated on them, but there are qualifiers. It's not as clean as you might want to believe, but in most cases, your provider should recognize making sure these other manifestations are present. Doxycycline, it's a very good drug. Not everyone tolerates it. It can cause photosensitivity. What does that mean? You get more likely to get sunburn on it. And I have a lot of people tell me they never get sunburned, and they go on doxycycline and they tell me about the worst sunburn they've ever had. Doxycycline can be used in a different setting for malaria prophylaxis. And so you're going to some place there's malaria, there's often a lot of sun, and a lot of people go on it and come back with terrible skin reaction, terrible sunburn, I should say. Sunblock doesn't always work. We tell people just kind of avoid the sun the best you can. It does cause GI upset a lot of times in folks. So the key thing with it is eat and drink while you're taking it. Your pharmacist will also instruct you on that little sticker about eating and drinking while you're taking it. Now, I'm married to an OB-GYN, so I can't help. I always have to put something about pregnancy in here. If you're pregnant and you develop erythema migrans or early disseminated Lyme disease, can you be treated? Well, it's obvious. They've never done any real big study taking a bunch of pregnant women and giving a bunch of them the treatment, a bunch from placebo. That would be lawsuit city, and no investigative review board would ever approve that. But what they've done retrospectively, they've seen a lot of women have been treated for Lyme disease and didn't know they were pregnant, and they went, "Oh, you actually did all right with this." Or they've realized that amoxicillin or cefuroxime are safe in pregnant women, so you can be treated. The exception is you can't take doxy if you're pregnant. So if you're pregnant, you still can get treated for erythema migrans. Important thing though to remember, and it's important to remember with any tick-borne illness, have to think about co-infection. And I really hammer this home to the providers, is that doxycycline works for Lyme disease and anaplasmosis, and I throw up ehrlichiosis up there, but that's carried by a different tick. But it treats those, but it doesn't treat this. So if you're not doing well after being treated, you have to make sure you consider being co-infected, okay? And we'll talk about that. Now, oh, look, they corrected it though. There's a lot of treatments in the press, in the public. There's a lot of providers, and call me naive, I think what they're trying to do is do what they believe is the right thing. There's a lot of different treatments for erythema migrans and early disseminated Lyme disease, but they're not evidence-based approaches. There's concerns in the end about safety and efficacy of these treatments. So I'll be ever so blunt. If you come to my office, I'm not ever going to prescribe any of these for Lyme disease, for any tick-borne illness, because there's no data at this time. Okay, that's my qualifier. I say to everybody who comes to my office, and they may tell me about another doctor, a book they read, and it describes some different treatment or some kind of new diagnostic. And the thing is, I apply, I mentioned before, IDSA and CDC guidelines, because I know that's the evidence that I rely on. That's the subject matter experts I rely on. This is the people doing the research, and I feel it's really well organized and really evidence-based that that's the treatment. It doesn't mean things don't change. The classic line is, when you graduate from med school, 50% of what you know is obsolete in 10 years. Things change. That's why I said to a patient the other day, I said, that's why I practice medicine. It's still a practice. We're still working on doing what's right. We're still learning. We're lifelong students. These treatments, there's no data supporting them. And I'd argue some of them, and I've seen patients, I won't go into anecdotes, I've seen patients significantly affected by some of these treatments because more isn't better, and drugs can cause a lot of problems. Think of anybody you may know in your life that's been on different treatments and they haven't tolerated them well. So you have to be very careful. That's my controversial moment.
Could you read a few of those, because we can't read any of those.
Okay. Oh, geez. The idea of multiple repeated courses of antibiotics for the same episode of Lyme disease, we're going to talk about when it comes to controversies. There's no data really supporting that. Longer term course of treatments, you're talking months, even years. No evidence supporting that. We're going to talk a little bit about that with controversies. Cephalosporins like Keflex, there's no data supporting that. Different penicillins doesn't work. You may be familiar with Levaquin or Cipro. They don't work. It doesn't work. Carbapens or vancomycin, these are more bigger gun antibiotics. There's no data supporting they work. Bactrim, Flagyl, these are other anaerobic drugs that don't work. Antifungals don't work. Hyperbaric therapy, fever therapy, ozone, I don't know how you do that. And intravenous hydrogen peroxide. These are treatments, people do stuff. And again, call me naive, and I want to be naive because I don't want to think people are doing this for nefarious gains, but these treatments they're not supported. Vitamin, nutritional management, I'm all for that. I mean, optimize your nutrition, optimize your vitamin intake, but I can't say with all honesty to you all that I think that's going to treat your Lyme disease. So that's kind of a quick run through of the many different treatments. I'll stop there.
Thank you, Chris.
Oh, no problem. Stop me if I'm going too fast here. So when we're talking about early neurologic Lyme disease, I'm not going to go too much. I'll break them into two different groups. Think of this as your seventh nerve palsy or your Bell's palsies, and think of this as your meningitis. Okay?
Great.
So this, when you talk about peripheral nervous system involvement, radiculopathy, cranial neuropathy, mononeuropathy, multiplex, think of what I'm really going to focus on is a Bell's palsy. Have you ever seen a Bell's palsy?
Yes.
You're going to see a picture of one.
Okay.
This is when we're talking about early Lyme disease, Bell's palsy I'm going to talk about. And down here, we're going to talk about meningitis. So Lyme meningitis. You'll all look very excited about that. So when we're talking about cranial neuropathies, it's the most common neurologic manifestation of early Lyme disease. And the seventh nerve palsy, or that Bell's palsy, is the one we see most often. And in Vermont, 1 out of 4 patients who present in non-winter months with a Bell's palsy, the origin is most often Lyme disease. So we see it quite often. And it can occur on one side of your face or both sides of your face, more often unilateral. And this is an example. I don't know who he is, I pulled him off the internet. But you can see here, the seventh nerve, the way you describe it, it's the nerve that innervates the muscles on the side of your face. And you can see here, look at the wrinkles in his forehead, they're gone. Look at his eyelid, he can't close his eyelid, okay? And he's smiling. How do I know what that's like? I had one of these. And imagine the neurologist who freaked out when an ID doctor walks in with the Bell's palsy. They thought I had every infection in the world. Mine wasn't Lyme disease. They don't know what mine was. You can get it from a virus. I got mine in the dead of winter. So it was just a virus that gave it to me. But it is, mine wasn't that bad. Mine was very subtle, I could tell it. But they can be pretty severe to the point where you got to worry about eye drops because you can't close your eye. And people wear eye patches. They have trouble eating. And it could be pretty significant. In a small minority, fortunately, have residual symptoms from it.
Is it painful?
I'll say for myself, no, it was painful because of pain around you couldn't eat. Chewing your bit on your lip all the time, but there isn't a pain associated to it, but it's very, I almost said unnerving, I didn't mean a pun there. It's very, it can be debilitating. Mine was subtle, but I know, and I hate to do that and make it about me, but I've seen a lot of other patients who've had it, and there's varying degrees. It's not like, people sometimes get this confused with zoster. You have zoster on your face. It's not, it's completely different. Zoster hurts.
Oh, yeah.
Shingles hurts.
Oh,
and you
my
can
God.
get zoster on your face, and you could have, you don't have the same neurologic manifestations, but it seems to cover side of your face.
Now, will his face stay like that?
No, over time, the vast majority of people, it resolves. And if you have Lyme disease, we treat it. All right, and it's the thought is with treatment, it's unclear if it hastens the resolution of the symptoms versus it stops it from getting worse, or worser, as my kids would say. But no, the vast majority of people, it returns over time, and it's very subtle. People, it's funny. I had people thought I had Botox. I'm like, oh, I guess I needed Botox. He thought I had it. And they saw it, or it sometimes because it's inside your face, they think you've had dental work. But it can be significant. We had 2 people, it was odd. We had 3 people in our ID section get it at the same time. It was a big academic section. And so we kept saying, oh, what is going on in the lab that someone's bringing out that we're all getting? And one of the women had it pretty significant, to the point where she had a lot of trouble eating. Because you can't, the food kind of sticks in the side of your mouth and stuff like that. So it can be significant. So How do you diagnose these people? The vast majority of people, as I said, will have lab testing positive. I'm going to go into lab testing, so hold off on your questions on that because there's a lot of controversy on that. Ask them about, or you should ask yourself, wait, did I have erythema migrans? Because they'll often have a history of it or one to 2 months ago. And also, don't be surprised if you go in with a Bell's palsy and your doctor tells you to take off your clothes. You know, he's looking for erythema migrans because we know if we see that rash, it kind of syncs them both together. In specific cases, and I'm not going to dig too deep into this, is they may want to consider, if you have other clinical manifestations, they may want to do a lumbar puncture. Because as you'll see, the differences between treatment is IV versus pills, and that's a big difference. And so your doctors or your primary care providers will look into, or the ED or me in the hospital, will look into for specific clinical findings. And you can see here, if you have severe prolonged headache or your neck stiff, I mean, it's a no-brainer, we're going to do it. We often say, if you think of it, you probably should be doing it, okay? There's a lot of debate on whether someone, do you do lumbar punctures? Are you familiar with that, the TAP? Do we do that for everybody? And I would say no, but you have to be have a low threshold to consider doing it because it does impact how you're going to treat people. Oh, want to go back? People taking notes. Don't worry, there's no quiz at the end. Maybe there is. Tell me when you're ready.
What antibodies or B?
Yeah, B-bordorphin. We could actually take we do a lumbar puncture, we get your CSF, and we could actually test antibody for it. Mayo Clinic has antibody testing that the Rutland Regional Med Center lab is fantastic. This is Department of Health totally is a great resource. Also, the lab in microbiology at RMC is excellent. They're able to work with Mayo Clinic, and a lot of these lab tests we could send off and we get results back in 4 days. So turnaround time is really fast. And we can do specific testing, and you'll see later on synovial fluid, meaning fluid in the joint. We can do it on your CSF. We can do quite a bit of testing.
What's the cost?
I don't know, to tell you the truth. Where'd that come from? I don't know, to tell you the
I
truth.
think it's expensive from what I was told, but
Nothing's
a
cheap.
lot of returns.
I don't know how much it is. I apologize for that. So, Matt will pay for it if you have any problems. Now, it's important, I mentioned before, and this is, I'm not going to dwell too much on this. There's a bunch of slides. I just wanted to present to you. It's important about differentiating between viral meningitis and Lyme meningitis. And there's certain clinical presenting factors that'll aid your provider of differentiating between the two, because again, the treatment's different. And there are certain telltale signs that are consistent. And just to let you know, when you present, we're not focusing on one thing. We have to make sure we have a nice broad differential. Treatment, I mentioned before, early Lyme, just a nerve palsy. The treatment is doxycycline again, amoxicillin or cefuroxime, and again, 14 days. But if we're worried about meningitis, we treat, you can see how different it is. It's IV and it's 14 days. So there is a difference in treatment. It's important to differentiate between the two. Move on. How am I with time, Matt? All right. Getting your questions mixed in here. So that's so case number 2. Mr. L is a 77-year-old male who was walking with a friend when he was noted to become more short of breath and tired. This isn't his baseline. He's usually an active guy. He tells you he's active outdoors, gardening and hiking. He also throws in there, and maybe I had a tick bite or a rash in the past, but that was 2 months ago, so I'm not really worried about it. Okay? You're worried about it. And you end up doing an EKG, and it shows he has a heart block. Any thoughts or questions on that? Well, what he has is cardiac Lyme disease. Interesting, historically, we used to see this in presenting untreated cases in 40% of patients. We don't see it as often now. And it's suspected that we're getting much better at identifying people early and not letting maybe it manifest to this point, but we still know it as a known entity. Symptomatic patients usually present with a varying degree of arrhythmias. And this is where cardiologists or your general internist or again, any of your primary care providers who present with these kind of symptoms are going to do an EKG. And you need to know they're looking to make sure there hasn't been a cardiac conduction abnormality caused by this infection, which it can cause. It usually presents 2 months, that's why I made the case 2 months after. It usually presents 2 months after the patient's infected. And look at this again, erythema migrans. They'll give you often a history of erythema migrans. You can get neural Lyme with it too, can occur right at the same time. So you can present with Bell's palsy and have an arrhythmia at the same time. You won the bad lottery in that case, but it does happen. But you can see in one review, of all the cardiac, the Lyme carditis cases, 85% of them had erythema migrans history. If they don't have erythema migrans, it's very important to do the lab testing. Again, we're going to talk about the lab testing, but the vast majority of patients you should know are going to have positive labs in the setting of Lyme carditis. If you have Lyme carditis, you may get admitted, okay? And we admit people who have either fainted or are very short of breath or have chest pain. Makes sense, most of these people are going to be admitted anyway. So our first case, or Mr. L, he would have been admitted because he's more short of breath and we're not too sure what's going on. We see this heart block, and you can see particular heart blocks, irregardless of symptoms. I bought you a nice bed in the hospital. And I just want to point out, this is probably as significant as can get. You can get a heart block. Your heart has an intrinsic rhythm, and you can get a block so bad that it basically separates the heart into two different pieces where the atria are pumping and the ventricles are pumping. And the block could be that significant.
So in 2 months, it goes that fast?
It can.
Wow.
It can. So what's the treatment? Have you seen these drugs before? Doxycycline, amoxicillin, and ceftriaxone, they're actually really good. Ceftriaxone is an option. What we often do with that is when a patient has an arrhythmia, we will often start them on ceftriaxone, especially if they have clinical symptoms. And then their arrhythmia may improve right when they're in hospital, right on treatment in days. And then we have them complete their therapy on pills. Sometimes it gets so bad you need a pacemaker either permanently or temporarily. And that's why when it comes to cardiac or Lyme carditis, I have throughout my career, we've always partnered with the cardiologists, and they're very familiar with it, and our cardiologists in particular are familiar with this. And we do see it. This is a real entity. Fortunately, we're not seeing it as often as we did in the past, but it's something that the ED here in town thinks about it, the cardiologists think about it. I get consults from the cardiology often because the cardiologists are saying, why would you all of a sudden have an arrhythmia? And they'll get a bit of a history of erythema migrans, or they'll do the Lyme testing and it'll come back positive.
Can you clarify something? When you're talking about this Lyme carditis, you're talking about people, these are their first presenting symptoms, so it's not like they found Lyme 2 or 3 weeks ago and they were treating it and now they have this.
It's a good point. This is what they present with. This isn't, okay, I'm sorry. So the question was, make sure I get this right, was this isn't they were treated and then they developed this kind of presentation. What usually happens is the person presents with symptoms of shortness of breath, chest pain, I'm passed out, and then they're determined to have this arrhythmia and then diagnosed with Lyme disease. Now, could somebody be seen in a clinic, started on Lyme disease treatment, but never really get assessed for Lyme carditis, and be on their Lyme disease treatment and complain several days into it? You know, I've been short of breath, I feel really lousy. Well, then they have to be assessed too. They should have maybe been assessed up front. It doesn't always happen because people present different ways, and we're dependent on, this is why knowledge is power in your case is, I tell patients, tell me everything you're thinking about, to a point, but tell me everything you're thinking about, because it's important for you not to hold back on anything that you may not think is important. So if you come to me, using Nancy's example, and you have a tick in you, and you have erythema migrans, and you're worried about this, and I had fevers, I felt lousy, and I start you on doxycycline, and then 2 days later, you call, or 3 days later, 4 days later, you call me and say, and I feel more short of breath now too. I didn't mention I was short of breath. It could have been that you could have Lyme carditis. That's what you could have presented with. You have Lyme disease, but you have Lyme carditis. Does that kind of make sense? Okay. pacemakers, I found in the vast majority of cases, there's no absolutes, the pacemakers are temporary. Okay, the arrhythmia resolves. But in some cases, believe it or not, we've picked up people who have underlying arrhythmias, and then the Lyme disease just exacerbated that. And so your bonus of getting Lyme disease is you were treated and now you get a pacemaker too.
I'm sorry, it's probably a dumb question.
No.
Arrhythmia, is that when your heart beats too fast?
It could be any type of, it could be fast, it could be slow, it could be, so an arrhythmia is an abnormal heart rhythm.
Okay. Sorry.
No.
Question.
Ask away. All right, we're going to talk about Lyme testing and the confusion of this, and I'll just read this. My son, my 14-year-old son loved this. My other kids didn't get it. Ha ha ha, Biff, guess what? After going to the drugstore and the post office, I'm going to the vets to get tutored. And my son just kind of looked at me and goes, you get it. And my other son's like, what's tutored? I'm not going to talk about that. Talk to your mom. So lab testing, a lot of controversy about lab testing, about testing for Lyme, a lot of confusion. I'm going to go into it a bit more when we talk about controversial subjects. But needless to say, it's actually a very good test, but it's got to be, like anything, it's got to be done right. There's a specific way you do the lab test. And if you do any, you try to skip ahead or you try to get out of order, you try to quickly interpret it, you're going to get bad results. So it's called a two-tier test, meaning the first tier is either a test called an EIA or an IFA. You don't have to worry about the specific of that. Just recognize that's kind of your screening test. And if that comes back positive or equivocal, meaning, yeah, it's positive, or we don't really know, but maybe it is, maybe it isn't, then we're going to go ahead and do this confirmatory test. So these two have to be done for you to have a lab test positive for Lyme disease. If that screening test is negative, you have to consider a different diagnosis. That is negative. That is a negative test. And that's it. It's fairly straightforward, but it's often confusing. I'll tell you where it gets a little confusing because it's not as simple as that. The lab testing, it's the first tier. I'll put it another way in words here. Positive or equivocal. And then that second test, this is where it gets confusing. You have to have these bands. And the way it's reported out can be very confusing. And I even show patients how I do it. I say, I pretty much know the bands, having done this for some time, but I pull it out every time, and I show the patients, I circle them. I said, these are the ones that positive. You need to have 2 out of 3 positive here, or 5 out of 10 positive here. All right, that's confusing. All you really need to know is you need to have the first part positive, or maybe, and the second part being positive, definitely, to make that diagnosis. You hear people say things like the serologies or the bands. And as far as I'm concerned, it's all about bands. The band is really important, and this is where most of the errors occur. Because you have to have the right set of bands tested for, and in those tests you have to have the specific ones positive. Okay? And I'm going to skip ahead and tell you a controversy. What's happened in some labs is, you can see here, it's 5 out of 10 have to be positive. Well, they'll say, no, I think there's 20 bands that really mean it's positive. So you look at your odds, you only need 5 out of 10, but now you need 5 out of 20. So there's certain labs, to be honest, we kind of joke about that. I'll send your labs to this one lab, and I guarantee you they're going to be positive because they've expanded these bands. The problem is, at this time, the data indicates only these are the relevant bands. It may change over time, and they may be right, but right now, this is where it goes back. We have to use the evidence we have, and these are the bands that have to be positive. That's all a question.
What is a band?
A band, it's an immunoblot. It's a way of, how do I describe it? It's a genetic snippet they're able to look at, and it's
Blood.
Yeah. Oh, it's from the blood. This is all from your blood, and it's the same sample. That gets a little confusing. I draw your blood. The problem is, historically, we used to do paper orders, and we still do some places, and they'd say Lyme serologies, and they'd only get the first half of the test. Or they write Lyme blots, and they'd only get the second part of the test. Now, fortunately, I know most hospitals are using the electronic order entry. When you order it, it reflexes to the second test. So you don't have to worry about going and getting it drawn a second time or something like that. But it's a blood test. I apologize for not bringing that up.
Are these tests for early Lyme?
These are early Lyme tests?
These are tests for really any Lyme, but there's certain criteria built into it. The IgM will more often be positive less than 4 weeks. These are more often be positive greater than 4 weeks. That's a really good question, because I'm going to say one of the controversies, again, I'm stealing all my thunder in advance, is the timing of when you do this. And also, do you even need to do this? If you have erythema migrans, you don't need to do this test. And I see all too often, I saw a patient in the last week that had erythema migrans but had an equivocal test and no one knew what to do with it. And I said, I know what to do with it. Forget it. We're going to treat you. And you guys know that too. So let's talk a little bit about, we're still good with time, late Lyme disease. We're going to talk about arthritis. I'm really going to briefly touch on these. I don't want you to dwell too much on these. We're getting really deep in the weeds with these. And I'm not going to talk about active dermatitis chronica atrophicanes. I just like saying it. So case number 3, Mr. J is a 58-year-old male who presents with a new right swollen knee. He doesn't recall falling or any trauma. He says he's very active. He's always on the move. He does recall a tick bite. He lives in Vermont, and a rash, but he was too busy to worry about it. Any thoughts? As my kid said yesterday, it's Lyme disease. I'm like, I'm talking about Lyme disease. So, rheumatologic Lyme disease. What's interesting is 20 years ago, more than 20 years, 60% of cases of untreated Lyme disease presented with Lyme arthritis, the classic swollen knee. And that's, if you look back, I mentioned before, the history of Lyme disease. These were folks, the young kids who presented with what was thought to be juvenile rheumatoid arthritis. It's actually Lyme disease. Now we see it in less than 10% of all cases. It's somewhat atypical. It presents as a single joint, sometimes multiple joints. Most often it's the knee, but we have seen it, and there's cases describing the shoulders and the hips, or even the TMJ. We'll actually see it. Less common though. The classic presentation, and this is one, I told you bullseye's classic, but you never see it, but this is, you do actually see. It's this knee effusion, swelling, fluid on the knee, that's really out of proportion, then that should really hurt. It really doesn't hurt, but it's a really swollen knee. That's a classic presentation. Sometimes people get Baker's cyst, and that's kind of a swelling in the back of your knee, an outpouching of your joint back there, and that could rupture and that could be painful. That's a little different. Basically, when patients present and they haven't been treated, to present with a history that's very different than a lot of other knee problems, say rheumatoid arthritis or other joint problems, is that you will get this knee gets swollen and then go away, and then get swollen and go away. Well, if you have a knee that's swollen and painful for more than 12 months, it's not Lyme disease if it's continuously swollen. It's got this episodic feature to it, which is really unique. But most people don't wait for months and watch your knee get swollen and go back down. Most people present right away. And here's some examples. These are actual knees of people who had Lyme arthritis. You can see on the upper left where the arrow is, look how swollen that knee is. And how swollen this knee is, how swollen you can see. Just look at the architecture of the adjacent knee. And with these patients, the knees don't really hurt. They can hurt, but not as much as you think they would.
Why does it go down?
It's thought to be, is it just the inflammation? They're not too sure, to tell you the truth, but it's episodic. Do you get these episodes of acute inflammation and then you get the resolution of this and it's more of a chronic inflammation with these peaks in it? I don't really know.
Maybe the more you do, it flares up?
I don't know. What's going to happen is if you present to your doctor with a swollen knee, what's the doctor going to do? You're going to put a needle in it. Those who are medical right now should be very disturbed by this picture because they're sticking a needle in your knee and they're not wearing gloves. As an ID doctor, I'm pained. I had to put that up. That's like there's a famous picture. The CDC or IDC spent this multi-million-dollar campaign that's talking about bad bugs, new drugs, and they have this healthcare provider wearing a mask, and it's really impressive looking. You look, you go, oh, the mask is on backwards. It's like you spent all this money on this campaign, and the mask is backwards. We like to bring that up again and again. So they'll stick a needle in your knee, and they'll draw fluid out, but it's not as impressive, and it won't show up like if it was a septic arthritis, if a bacteria, say staph or strep was growing in there. The confirmatory test is that blood test. Patients with Lyme arthritis are going to have a positive test for Lyme disease in their blood. What we can do, and again I mentioned before, our lab has the capacity that if fluid is drawn out of the knee, we could send it for PCR, and that's looking at really specific pieces of genetic material, and we can look at that fluid in the knee and see whether there is Borrelia burgdorferi found in that knee. And that really adds to your diagnosis. That kind of cinches it. You're like, all right, that fits. I got a right story, I got the lab test, the blood that shows positive, and now I get the knee fluid that's positive. So that person has Lyme arthritis. We'll talk in a second on how you treat it. But if you get a blood test and it's negative, then you're like, wait, I don't know if I'm dealing with Lyme, but what ends up happening is it's life. Someone will stick a needle in that knee and still send that PCR off for Lyme disease. And inevitably, of course, when you don't expect it to come back, it comes back positive. But it doesn't really mean anything. We don't know what it means. It means you need to look a little deeper. And it could be just a false positive because tests aren't perfect. There has to be sequent events that occur. And so we really say it's not diagnostic. We can't make that diagnosis just on the fluid in your knee. We need to see the blood and we need to see the fluid in your knee.
What does PCR stand for?
It's polymerase chain reaction. Just PCR is the easiest way to say it. Yeah. Treatment. And this is where it gets tricky. Look at those drugs. You've seen those before. But here's what's tricky. Look at that.
Oh.
It's 28 days. We used to treat, and those of you who are been maybe have had friends or had a tick-borne illness in the past, we used to treat almost everyone for everything with 28 days. It used to be 21 to 28 days, 21 to 28 days. Realize we don't have to treat people that long. But with Lyme arthritis, we still treat for 28 days. There's more. Again, this is a little qualifier I gave to my colleagues about you got to make sure you rule out neuro, you got to make sure you rule out a lot of other things too. What happens is, and I call this Lyme arthritis treatment 2.0, there are patients after treatment who have persistent or recurrent joint swelling. Even after 28 days, we often treat them for another 4 weeks. It's the only real time that you'll hear an ID doctor stand up here and saying about retreating for Lyme disease. Okay? It's the exception. But before you jump into treating, it's recommended you wait several months before initiating it because there's this inflammation we mentioned before, and it takes some time for this to resolve. And you have to be, I say to patients, I usually step away and make sure they're not holding a drink or a urinal or something like that. I said, you have to be a patient because it takes time for these to resolve. And we tell people in the interim, take NSAIDs, Advil, stuff like that. Don't let your doc do a steroid injection in that knee. It's not recommended. But over time, the majority of people after that first course do well. And if they don't do well, you wait a little time after that to see if they've made some progress, and you retreat them. If you go, now you've gone 56 days of doxycycline. That's a lot of doxycycline, and there is still, we're whittling down to fewer and fewer people. We still have some people who still haven't improved. And at that point, we tell them, go ahead with the NSAIDs, the Advil, the Aleve. You could have your doctor. By this point, you're often seeing a rheumatologist in conjunction with your ID doctor or orthopedic surgeon. And what we recommend at that time, they can give you the injection of steroid into your knee to help that joint, if that's the affected joint. There's these disease-modifying anti-rheumatic agents, drugs. Something like hydrochloroquine is an example I give. But at that point, you're seeing a rheumatologist and they're directing those therapies. There's still a very small minority of people who still don't do well. And in that case, if you have persistent synovitis, inflammation in the joint, and at this point, often people will have pain and limitations in function. They've gone through this now. We're talking months and months of potential debilitation given this infected knee. At that point, you're going to meet our colleagues over at VOC, and what they often do is they do an arthroscopic procedure to kind of reduce the inflammation that way. We are fortunate in this day and age. We are not 25 years ago when we were seeing over 60% of cases with untreated Lyme presenting with Lyme arthritis. It is a minority of cases, And we're lucky, we're very rarely getting this point, but it exists. Okay? And I thought it was important to bring it up to let you know. In this case, we treat longer, we treat more than one time, and even then, sometimes we have to proceed with surgery. It's the only really Lyme disease associated illness that proceeds to this extent. All right, this is where I'm going to click through quickly. So, late neurologic disease, you have encephalomyelitis, peripheral neuropathy, encephalopathy. These are really indolent forms of neurologic disease, and they're very rare. And you can see this is primarily diagnosed in Europe. And don't take notes on this. This will not be on the test. You can see this neuropathy. We've heard about neuropathies in other conditions, but this is where you get the stocking glove or diffuse process. And there's particular testing you could do. Treatment, ceftriaxone. Notice there's no doxy, ceftriaxone, and amoxicillin in this one. And you can see there's encephalopathy. And they can be very confusing because they can mimic other diseases. Enough on Lyme disease. I'm still good. There's other tick-borne illnesses. Mr. S is a 75-year-old male who presents with new fevers, chills, fatigue, worsening headache, and muscle pains. He's very active. He recalls a tick bite about 2 weeks ago. He has labs done. His white count's really low. Anything less than 4.5 is low. He's low. His platelets are 78. Platelets are used what you clot. Normally, anything below 150 is low. And his liver function tests are elevated. Our lab has done this multiple times with me. They'll call me and they'll say, "Ah, look, we see this." Any thoughts on what this is? Which one? No? It's a good guess though. Anaplasmosis. It's anaplasmosis. The formal name is human granulocytic anaplasmosis, or when I was a fellow, they really confused you because it was anaplasmosis, but they call it ehrlichiosis. Don't ask me why they did that. But they did. And it's a tick-borne infection. It affects neutrophils, or white blood cells. And the agent you can see is Anaplasmosis phagocytophilum. It's our Ixodes scapularis tick. After you get bit, it's 5 to 21 days you can present with these symptoms. And it's seen where we have Lyme disease. And it's not diagnosed, remember, in children. We just don't see it in children that often. People present with fevers, chills, headaches, myalgias. And you get these abnormal lab findings. Their white count is very low, and that's part of the white count. Their platelets are low, and they get their enzymes in the liver that go up. Most cases are mild, self-limited illnesses and resolve within 30 days. This was historically, I had one provider describe this to me as the summer flu. People would get sick in the summer, and they didn't know they actually had anaplasmosis. They'd get sick, and it would resolve. But serious infections can occur. We've had quite a few people admitted to hospital just this summer with anaplasmosis. And as you remember from the original slides, there are fatalities associated with it. So who tends to do worse? And it's if you're, pardon me? Yeah, the seasoned people. If you're on immunosuppressive therapy, and that's a huge group now. That is if you have Crohn's colitis, you can be on treatment. If you have rheumatoid arthritis, if you have had any type of chemo, if you've had an organ transplant, this is actually, you have bad pulmonary disease and you're on high dose steroids. This group is actually rather big. We don't think of it, but the group's growing and growing. And those with any chronic inflammatory illnesses. Prior to antibiotic therapy, so if someone first presents, we actually could see it. Not always, but it's nice to tip off, and the lab's really good about picking it up. And I'll often swing by and I'll mention them. I'm thinking this person had anaplasmosis, and they'll look. And you actually could see it, and it's really, in the right clinical context, is pathognomonic, meaning you've made your diagnosis. You can see, this is just the ID doctor gets all geeky about actually being able to see something in these white cells. But that is it's called a morula. That's the name of it, morula. We can do, historically, the best way of diagnosing this is you did antibodies. Okay, now we also do PCR testing again. We could do both these tests, send them in the mail, and they're back in 4 days. All right? It's a very good way of diagnosing people, but what's important is we don't wait. If you present, and I'm concerned about anaplasmosis, I start treatment. I don't wait till the test results get back. I start you right away on treatment. So if though you're a patient who presents and for some reason someone did antibodies and they're positive but you have no symptoms, we don't treat you. There's no indication to being treated because basically the thought is you have antibodies given to a prior exposure, you don't have the illness right now because you're asymptomatic. But if you're symptomatic, you should be treated. I mentioned you should be treated right away. And the treatment is, again, ticks don't like doxycycline, and doxycycline loves ticks. And it's 10 days. And what's pretty amazing is, and I'll have it in my slide before, is it's such a quick resolution in symptoms. You treat someone with anaplasmosis, and in 24, 48 hours, they're a new person. And they've been feeling lousy maybe for days upon days. And I could give an example of a patient we had admitted. He was one of these complicated patients with all these other medical problems. He had post-splenectomy and this and that. And he was really sick. Came in, was admitted to the ICU. And again, the family said it. Said, I don't think this is important. But he was out in the woods and he got some ticks on him. And we're like, oh. So we started him on his treatment and we added the doxycycline. And within the first day I saw him, we were afraid he was going to have to get intubated and all this. No, he was talking to us that day. Hey, what happened? We're like, oh, talk to your wife. You're in big trouble. But it was pretty dramatic the way people respond to it. Now, again, not everyone can take doxycycline, so there are alternate treatments. And the one treatment we have is rifampin. Rifampin, if you look it up, you'll see, oh, look, TB. Oh, look, all this other stuff. No, it's actually used for anaplasmosis. Not studied as much. So we're really picky about following you after you get started on it because we know it's not 100%. It's not as successful. I won't say 100%. It's not as successful as doxycycline. And we also worry about co-infection because remember, doxy gets Lyme disease and other things. So if you're worried about Lyme disease maybe at the same time, we often tell people to add the Lyme disease treatment at the same time. Rifampin. I know when people are taking it. How do I know when they're taking it? Has anyone been on rifampin? What do you do?
Sweat orange.
You pee orange. I know when patients tell me they're not peeing orange, I'm like, I don't think you've taken it. And then the wife goes, yeah, he's peeing orange. I don't want to know how. But the treatment, like I said, within 24, 48 hours, pretty dramatic response. And if they're not responding, you have to think, maybe I got to consider a different diagnosis.
Question.
Yeah.
So how do you know if you just have the flu or,
You got to get tested.
so anytime you,
If you've been bit by a tick, or you think you've been exposed to a tick, that's easier. If you develop these symptoms of being bit by a tick, you should be tested. If you don't know whether you've been, you could still be tested. But like I said, a lot of these cases are mild and people never present even to get treated. But I wouldn't mind if people were more vigilant because it would also allow us to know how many cases we have in the state too. Because we have a metric of how many cases in the state, but how many people never presented.
so better safe than sorry.
I'd recommend that.
Okay.
I just met a lady July 3rd, and she said she didn't know she was bit by a tick. She went, her doctor's in Bennington, she lives in Wells, Vermont. She had that anaplasmosis, and they put her in the hospital. She said she had renal failure, and they put her on intravenous.
Yeah, you can do it. If you're sick enough to be admitted, we often will put people on Doxy, IV. There's no difference
And now
between.
she's on the pills, but
Yeah.
this is July 3rd, and she said she feels horrible.
Yeah,
She's so
you
tired
want-
all the time.
And you have to make sure there's not something more going on. The pill and the IV is the same. I know sometimes people will come in, they're feeling so nauseous, feeling so lousy. We'll give them the IV for a day or two till they're feeling better, and then we'll switch them over to the pill. But rest assured, it's the same treatment. So here's our final case. Mr. V's 39-year-old male with new fevers, chills, sweats, nausea, doesn't want to eat, and joint pains. He describes himself as an athlete. Like most 39-year-olds think they are. And he thinks maybe I'm just sore from working out. I got a cold for my kids, but my wife made me come. He tells you this is ID, this is what happens all the time. Oh yeah, I was in Brazil 2 weeks ago, and then just last week I was at my small summer house in Martha's Vineyard, and I just don't feel well at all. And so he's at Martha's Vineyard, and then he tells you more. Oh, I wasn't in Rio. I went on an Amazon tour. And you're like, oh, tell me about that. Oh, I got bit by every bug. I didn't take any of those meds that you people try to make me take because I'm a 39-year-old healthy guy. And that's why people say, I never get sick. And I often go, why are you here then? You're seeing an infectious disease doctor. You say you never get infections. Aha, you're here seeing me. So what's your thoughts? Is this malaria or is this babesia?
Ehrlichiosis.
No, it's not ehrlichiosis. It's babesiosis or malaria.
No,
They present very similarly. Babesiosis.
Yeah.
And so it's important to remember, and this is where history comes in, is this is where you see babesiosis, but that's every place you see malaria. In this case isn't an actual case by the details I give you, but this was a presentation I had when we were fellow at Dartmouth where a person did this. And we're like, you've got to be kidding me, because the treatments are very different. And we leaned upon our section chief, who was brilliant, and he said, I'll bet my career that this is this, you know where this is going. And so Tuesday morning we rounded, head of microbiology there, and we're like, doctor, I won't name him, said it's malaria, and he bets his career on it, and he goes, looks like he's retiring soon. So it's tough, but we're fortunate in that we will get a review here at RMC and at other places, at DHFC or UVM, where pathology can look at these and tell the differences. And it can be very confusing, but they're very nuanced. And you can do PCR testing for babesiosis that again comes back in 24 hours. So this is caused, again, by Babesia microti, most common in the United States, Ixodes scapularis. It's an intraerythrocytic, or it basically is in the red blood cells. Interesting fact is there have been reported cases by blood transfusions. Okay. Very uncommon now, we're getting better and better at screening our blood, but there were cases of transfusion. I just thought I'd throw that in there.
So are they screening for that?
Yeah. I don't know when they started screening for it, but it's not considered as much of an issue now as it was previously because we didn't recognize it as we did now. But they do, the screening they do in blood, it can never be absolute because newer things show up, but they do screen for it now.
You don't know what year it is.
I know. Higher incidence areas I mentioned, coastal, southern New England, the beautiful people. You could present as symptomatic, but this is also rapidly fatal. And the patient often presents, again, look at that, a summer flu. They feel kind of lousy in the summer with fevers, chills, sweats, joint pains, muscle pains. They don't want to eat, they're nauseous, they're vomiting, and they can be really fatigued. On exam, these patients always present and have high fevers. We often can tell they have an enlarged spleen, they have an enlarged liver. They often come in jaundice. They come in looking a bit yellow. And you can get a lot of different lab abnormalities. You get an anemia. You can get, your platelets can go really low. You can get a lot of spilling, a lot of protein, and you have kidney problems in your urine. Your liver functions askew, and you can get bad kidney disease. You can develop, as I mentioned, kidney failure from this. There's certain populations that are at higher risk. And these are, if you have your spleen removed, if you have a malignancy, if you have HIV or you're 50 years of age, which I consider very young. It's a disease of young people. And what could be the complications? People could end up in our ICUs intubated, sedated, on pressors, with bleeding problems, with fluid in their lungs, with their kidneys failure, being in a coma, and people die from this. This is a very serious illness. The way you diagnose this is you have to have traveled in an area where there's babesiosis, Vermont, or down in, I mentioned Martha's Vineyard, Nantucket. They will see this on a slide. They will look at a smear and they can see it. Also, this is the most recent recommendations if you've had a transfusion within the last 9 weeks. But I don't know when they screen the blood, but they like to, if you had a transfusion, the docs want to know, just to make sure they're keeping it in mind. Remind you where it's endemic, right here. And what's interesting is they will do smears and you can see it. And this is, again, the ID doctors being a bit geeked out. This is a famous sign, which you probably don't, I appreciate it. If you don't, it's okay, because, well, it's not much to appreciate, but it's called a Maltese cross. When the pathologists get all excited, they say, oh, we saw a Maltese cross, that's pathognomonic for babesiosis. You will see this inside. This is the products of the red blood cell burst, and you see this is the babesia right there. This is the babesia right there, and this is it right there. It's all in the blood. And they can measure what percentage of cells are infected too. We can do PCR testing and we can do antibodies. We have a lot of different ways to test for this. All patients with active babesia should be treated with antibiotics because of the risk of complications. And you recall, how do you diagnose somebody? They've had maybe that viral illness, they live in an area there's babesia, and we see it either in the blood or the PCR comes back positive. These people need to be treated. This gets a little confusing because there are populations we don't treat. For example, if you have symptoms and we see the antibody, but we don't see the PCR in your blood, it's not recommended to treat you. It's thought to believe that you may have had the infection in the past and you're clearing it or having cleared it, but it's not believed that you have active ongoing infection. And so you have to weigh the risk of the treatment versus the not treatment. And these treatments aren't benign. You'll see it's a different treatment. It's not your good old doxy. It's a different drug in this case. And so we don't treat these people. And that's Ron Burgundy saying, what did you say? And again, you don't treat these people. But we do have patients who are completely asymptomatic, feel great. And for one reason or another, they have either serologic testing or they have blood smears or PCR, and they're positive, but they're completely asymptomatic. We don't treat them, but we treat them a little differently. We'll follow you for up to 3 months, and if you still have this babesia in your blood, we're going to treat you. Don't ask me why. It's just where we are right now. We try to, hopefully your own immune system will clear it and we don't have to introduce these drugs into your system. But in some cases, we just want to make sure it's cleared. It's that important because it can cause problems. The treatments are atovaquone and the zithro for mild cases. Believe it or not, that's your good old Z-Pack. Atovaquone's a whole other animal. Clindamycin, many of you have probably been on, but quinine is another drug. And that could cause, again, it's not without its potential complications with cardiac arrhythmias, and you have to be monitored while you're on it. Don't worry about that. That's just a slide demonstrating the different treatments. Some people are so sick that they need to have what we call an exchange transfusion. Basically, you're hooked up to a machine, we are taking your blood out, we're putting other blood in you because we have to get rid of this parasite out of your system. When I was at Dartmouth, we had 2 cases like this, and we were checking the parasite load or parasitemia every day, and this person who we first saw had about a 45% parasite count. So 45 out of 100 of his red cells, they were seeing the parasites sitting in there. And so we treated him with the antibiotics, and then we exchanged, basically, we took his blood out and put new blood in him. And that's the treatment. They won't do that at RMC, I apologize. You're going to Dartmouth or you're going to UVM to get that done. These patients can have an awful lot of problems. So that person who has renal failure likely needs that. That person who has liver failure likely has that.
Do those conditions, the renal failure, get better?
Yeah.
They get
With that treatment, yeah. The outcomes for mild to moderate to severe, you got to closely monitor them. If you get that aggressive treatment, the literature shows within 48 hours you actually start to see improvement. It can take a long time. It can take upwards of 3+ months till people really feel resolution of their symptoms. The key thing is you really have to closely follow up these severely ill people. All right, I'm going to move I did a lot of these already, and this is the last section, then I'm going to take questions. I apologize for taking so long. See, there's an awful lot to say. We'll start with this idea that ID doctors are ignoring the problem. I put up these 2 statements from the IDSA, and IDSA is really invested in understanding not just the initial tick-borne diseases, but these clinical manifestations people have, these objective findings of abnormalities after being treated and understanding what's going on. And we don't really understand it, and research is ongoing. But we don't want to jump ahead of ourselves and start people on treatment when we don't really find it's maybe a benefit there and we could actually do harm. And again, IDSA partners with CDC and NIH, and these are the government bodies that are funding research. It's very helpful. People argue, oh, our guidelines are out of date. It's the idea whenever you buy a textbook, the minute it's released, it's out of date because things have happened since. And that's the nature of the beast, but they're pretty good about updating the guidelines. The guidelines, the most recent guidelines I'm referencing are from 2006. They were re-reviewed in 2009, and I mentioned that in one of the, how politics and tick-borne diseases cross paths. In 2009, it was re-reviewed, and this coming year is the newest version. You're hot off the presses inside baseball. I have a friend who's a reviewer on it. So not many dramatic changes. Pretty much the same kind of clinical approaches. This idea that tests aren't good, we've talked about this. I apologize if it's to some of you ad nauseum, but this two-tier testing has to be done. You have to use the bands according to CDC. The problems are people adding these extra bands to improve the likelihood of positivity. The problem with ordering the test out of order. The problem with the test being ordered, and it really doesn't have to be ordered because you have erythema migrans and you're done. And timing. If there's issues, someone mentioned, is this test used early or late? I think it was you right there. You get credit for that. When in doubt, what your doctors could do, and you could recommend, test me and test me 4 to 6 weeks later. And because early, you're presuming your body's making these antibodies, and sometimes the body takes a little longer to make antibodies. So that's where it's acute and convalescent. That's where that idea comes from. Prolonged symptoms, this is what was brought up earlier. What if you have symptoms that continue? And there's an awful lot of confusion out there about this. And I'll kind of walk you through a bit of it. Most patients promptly and completely have resolution of symptoms with Lyme disease. That's most. That doesn't mean all. That's most. What we see is people rarely have objective, things we can measure, findings post-Lyme or post-tick-borne illnesses that we measure that are abnormalities. A lot of people have subjective symptoms. Doesn't mean they don't exist, but we just don't have the tools necessarily to measure them correctly. In one large review, found of all the patients they treated, less than 10% had measurable findings that demonstrated a continued abnormality. The majority of people had these subjective findings. And that creates a lot of confusion. That's where a lot of research is going into it. And where it's going into is they've yet to demonstrate an active ongoing infection. And I'm going to mention this a little bit, but this idea of you still are culture positive, there isn't any study that's been reproducible demonstrating that you have continued Borrelia burgdorferi in particular in your system. And I know that gets a lot of people upset because there are a lot of people who quote studies, and there's 3 in particular. One is a study that, believe it or not, the medium they used to grow it was Detroit tap water. I don't know what's unique about Detroit tap water. I guess it's better than Flint, but it's Detroit tap water. And the problem is they never were able to reproduce it. There's another study that said we are growing the Borrelia from your urine. It hasn't been validated. We haven't seen this repeated. And the most recent study is a lab in New Jersey. A colleague of mine just told me about this several days ago, that came out and they said we have 100% positive results for people with chronic Lyme for Borrelia. Well, that's a problem. If the lab's always positive, then how true is that lab? And the problem is they found out it was when you do a test, you do a control to make sure the test works. What they were finding positive was everything they were control testing for, which was a European strain of Lyme disease. So unless all the people were sending their stuff were from Europe, the test really isn't that good. And so this idea of an ongoing infection hasn't been proven, but there's thought that maybe what we're seeing is you were sick, and what it did is it triggered this kind of inflammatory cascade, meaning your system's really turned on to fight infection, and this infection has made it so it's not turning off. It's one theory, and it's this idea of this dysregulation of the immune process, kind of like an autoimmune problem. Again, we don't know. But it's a controversy within chronic Lyme. Is this the cause? And there's a lot of research going on with this. What they found is if you're sick, or if you have a lot of complaints before you get Lyme disease, you'll likely have those same complaints afterwards, and they're not always attributable to Lyme disease. And it's really blunt talk, and people don't like hearing that. But I use the example of the guy who breaks his hand and he goes to the orthopedic surgeon and says, "Doc, will I be able to play piano now?" And the orthopedic surgeon says, "Yes, you can." He goes, "Good, I couldn't play piano before." I mean, the problem is, if you had medical problems before, It may be that it's not the Lyme disease, it's those medical problems. It may be that it exacerbated them, but it's not necessarily the Lyme disease. And we found with patients who have a lot of comorbidities, say they have diabetes or peripheral vascular disease and thyroid problems, they take longer to have resolution of symptoms. That's somebody who's healthy, and that just is common sense. You have to though remember co-infection. I mentioned before, don't presume if the symptoms are better that it's, oh, this is taking time. You have to make sure as a provider, to make sure you're not ignoring possibly a co-infection with another tick-borne illness. And also CNS, because remember, that's neurologic illnesses from Lyme disease, different treatment, so it's important to sort that out. You need to consider alternate diagnoses. There's been some really interesting studies that had patients who presented to university-based ID clinics with the diagnosis of Lyme disease, chronic Lyme, and the vast majority were found to have alternate diagnoses. Things like fibromyalgia, myasthenia gravis, multiple sclerosis, rheumatoid arthritis, bursitis, depression. What can happen is we can get tunnel vision into thinking this is the diagnosis. There's the term Occam's razor, where everything is together and unified into this one diagnosis. Well, it's not always true. You may have had Lyme disease, but it may have now revealed itself, not as Lyme disease, but actually it's another illness. Now, a classic example, I didn't really go into them, is patients who are termed to have late neurological disease, encephalomyelitis. A lot of them have multiple sclerosis and it's missed. Very different treatment. And I would hate to think that we have our blinders on to any other diagnosis. And it doesn't mean, it's not a wrong or right thing as far as, oh, judging people and this or that. No, it's about treating people and making sure we get the right diagnosis because the treatments are unique for each entity. Prolonged treatment, many studies, I know someone asked before, what about treating for a really long time? There's been study after study looking at this using long-term IV, and they placebo. They'll give someone ceftriaxone IV, and they'll give someone a bag of saline, so you don't know the difference. And they'll look at the end of these studies, and they found the placebo people were just the same as the treatment people. So there's no benefit. The actual downside is people develop, when they're getting antibiotics, getting allergic reactions and stuff like that. And so you have to be careful. There's no data supporting that. And there's actually just a report out about a month ago that, and you can look at it, it's right in CDC's report, and they described, it was actually kind of a horror show, describing folks who were on long-term IV treatment, developing everything from endocarditis, that's a heart valve infection, to developing other bacteremias, and one or two of them passing away, dying from septicemia, because they had to have this IV to get this treatment, and it really wasn't indicated at all. Again, more on prolonged treatment. All these societies kind of, at this time, given the data we have, don't recommend it. A lot of unclear statements out there about Lyme disease. Again, we mentioned the culture data, really no data indicating that. And what's interesting too is some folks like to attribute, this is a spirochete, a type of bacteria, they're attributing these unbelievable qualities and characteristics to this infection that's seen in other infections. And I think, again, maybe it's true, but we just don't have the research supporting that. So I think we have to be careful about skipping ahead without understanding what we're saying, because it can impact what kind of treatments we apply to people. There's research. The problem is, historically, although we're getting better, is everyone had a different definition. Goalposts were being moved, the way we're describing these patients. So you'll see some studies describe a group of patients and draw a conclusion, while another study saw the same population but tweaked the way they defined it, and it really created a lot of confusion. We're getting better with this. There's a big political issue. Again, Google it. I'm not going into it. I'm from Connecticut originally, where politics got involved in tick-borne illness and healthcare, and we all know how politicians do when it comes to healthcare issues. And finally, this is a quote by Paul Oler, who was a prior president of IDSA, where he really described, unfortunately, the state of Lyme disease and chronic Lyme illness as a poisonous atmosphere. And I'm not denying there's a lot of anxiety and stress and controversy associated, but from my opinion, we can't ignore it because it's a real entity. And that's why I thank you all for coming tonight, because there are facts we know and stuff that we still need to learn an awful lot about. But we need to all start at a certain point of understanding and say, we may disagree, but we have to agree on certain things, and that's we We got to treat people and get them better. I'll stop there if there's any questions.